So it's my pleasure today to introduce Dr. Elizabeth Tucker.
Hello.
She's one of our third-year chiefs and is, this is part of her fulfillment of residency. Every resident does a career round. And she's got a very timely topic as far as influenza. We've been public cases in the region, I believe. But, and it's interesting, she may talk about this, but the peak changes every year. So I specifically remember in 2003 that the peak was in November, which was very early. The reason I remember that is because yesterday was our anniversary. And so I had taken the week off before and the week off the week after, and so I was out of the hospital for most of that, which also meant that I didn't get the flu. So anyway, very timely topic, and we're interested to hear what Dr. Tucker has to say about influenza.
Thanks, Dr. Cooper. Okay, so my topic today is influenza. I have nothing to disclose. So my objectives for this this talk are to outline the impacts of influenza annually, so to discuss how it affects us, to integrate the current guidelines into our clinical practice, so to review the guidelines for vaccination this year so that we can effectively apply them in clinic and in our practice, and then to identify parental hesitations and respond appropriately. So sometimes when we offer the flu vaccine to children, parents are a little bit hesitant to give it due to some myths about the flu vaccine, so we'll address those and then discuss ways to talk to parents about it. So why is the flu important? Annually, the flu causes a significant clinical and economic impact. Vaccination is the key to preventing flu and controlling it. And healthcare workers are a valuable link in the promotion of vaccine and in decreasing infection. So a little bit of history about the flu. Influenza comes from the Italian word influential. It was named in the mid-1300s, and it was believed that it used to be a result of astrological influences. After that, the flu infection was attributed to Haemophilus and was thought to be bacterial in nature until about 1931, when it was isolated from the mucosal cells of pigs by Richard Shope. The flu is an Orthomyxoviridae family. It contains a single-stranded segmented RNA genome, and there's multiple subtypes such as influenza A, B, and C. A is primarily responsible for disease. B causes some disease as well. So on the surface of the flu virus, there's two major glycoproteins. The first one is hemagglutinin, and the second one is neuraminidase. The hemagglutinin, it's the major protein. It's what helps the flu virus attach to the host surface receptors, and it mediates the fusion of the virus in the cell membrane. So the flu virus, when it infects a host cell, it replicates in the nucleus. Because it's an RNA virus, it uses the host cell machinery to replicate their virus, and there's no proofreading. So there's errors, like single mutation errors are common, which causes changes in the virus genome. The other thing that can cause changes in the genome is that the virus is segmented, and so when it packages itself, it can pick up different segments of the gene. So antigenic drift is where there's small changes in the genome. This produces viruses that are closely related to each other, so they have similar antigenic properties. These viruses, if you have an infection with one previously, your immune system may recognize a new virus with a slight change to it. Antigenic shift, however, this happens only occasionally. It's an abrupt and major change in the virus, and it results in a new H or H and N proteins on the virus to infect humans. Generally, these viruses emerge from the animal population, and it happens when an animal virus and a human virus are in the same cell. So with their segmented genome, the viruses can rearrange, the genome can rearrange, and a new virus emerges. Because these are a new virus, most humans don't have immunity to the virus, and that gives them the potential to spread quickly and cause pandemic. And that's what happened in 2009 with the H1N1 flu. So this is a slide showing an antigenic shift where the flu is normally in the wild bird population. It infects a pig. That pig is infected by a virus from the human as well. Those cells rearrange and you get a new virus. So how is the flu virus named? They have really long names. First off, you start by the virus type. Is it influenza A or influenza B? Then they're classified by their geographic location where they were first isolated. Then they have a sequential number of isolation, the year of isolation, and then their H and N subtype. So this is an example of a flu virus. You can see it's type A. It was isolated from flu gene. The sequence is from 2002, and it's H3N2. So, modes of transmission for the flu virus. It's spread by droplet and aerosol. When people cough, sneeze, and talk, they have small droplets that contain the virus, and these can travel up to 6 feet. The virus can live for a short period of time on surfaces, so when people touch things such as doorknobs, tabletops, anything that other people who have been infected have touched, and then touch their eyes, nose, mouth, they can potentially infect themselves with the virus. The virus causes infection by attacking the respiratory epithelium. It usually does not travel beyond the respiratory tract, and the systemic symptoms that you get of fever and chill and everything, those are from the cytokine release and the fighting the infection. So the illness, generally people are contagious for a day before the illness begins and up to 7 days after. Children, however, can be infectious for more than 7 days. Some people, it takes up to 4 days to show signs of illness after the virus enters the body, which means that you can feel just fine and be infected and transmit the virus, which is one way that it can spread quickly. So the symptoms of the flu include dry cough, severe or significant fever associated with chills and sweats, aching muscles and fatigue, headache, nasal congestion, but not necessarily rhinorrhea, but more like just congestion, and then it causes nausea, vomiting, and indigestion. So sometimes it's common for people to say that they have the flu when it's not a documented case of the flu. So how do you tell the difference between a cold and the flu? Colds tend to be mild to moderate symptoms, although there are some really bad colds that can cause you to be pretty sick. Colds tend to have no fever or a mild fever, like a low-grade fever. And colds tend to have more of a productive cough, chest discomfort, congestion, and rhinorrhea. Whereas the flu, you have a more severe illness. They tend to have a high fever with chills. People have a dry cough, so they don't necessarily have the phlegm and the productive cough. And then they have more severe systemic symptoms as well. One of the key things that differentiates the flu versus a cold is that the flu can lead to severe complications and death, whereas a cold is much less likely. So everybody's at risk of getting the flu. People in specific categories are at a higher risk of hospitalization and death. This includes children under the age of 2 and adults over the age of 65. people who have a chronic disease such as pulmonary disease like asthma, COPD, cystic fibrosis, those people, anybody with cardiovascular disease, people with diabetes, and people with renal disease. There's also many other chronic diseases, but those are just some examples. People who are immunocompromised, such as transplant recipients, people undergoing chemotherapy, people who are HIV positive, or people who have splenic dysfunction. And then pregnant women are at a higher risk of getting influenza and having severe complications. So the complications of flu, they range. Some people can get severe illness requiring hospitalization. Some people it can lead to pneumonia. Pneumonia is particularly common in people who have lung pathology to begin with. Some, in rare cases, it can cause myocarditis, encephalitis, myositis, rhabdomyolysis. You can get multi-organ failure, and then it causes worsening of chronic conditions. So if you're already not in the best health when you get the flu, whatever condition you have can get worse. So there's been a few flu epidemics in history. The first one that's kind of recorded and is thought to be the most severe is the flu epidemic of 1918. That was the H1N virus. It infected about 50 million people worldwide, which was a third of the population, and it was attributed to 50 million deaths. One thing that's unique about the 1918 strain of the virus was that most of the deaths were in people less than 5. The young adults that are between the ages of 20 and 40, and there were fewer people over 65 that died from the virus. So it was mostly young people. In 1957, there was 1.1 million deaths worldwide. 1968 was the new virus H3N2. There's about 10,000 deaths worldwide, and this was mostly in people greater than 65. And then in 2000, there was a recurrence of the H1N1 flu strain. This one was unique because it hadn't been seen in high numbers since the 1918 flu. It also came late in the season. It didn't start until about April of 2009. And so it peaked late. There wasn't, at that time, a vaccine for it. And so a lot of people, even though they had the flu vaccine earlier in the season, they didn't have any protection. They did try and make a flu vaccine for it, but it wasn't offered until November. And by the time it was offered, most of the epidemic had gone away. In 2009, between April 12th, 2009 and April 10th of 2010, it's estimated that 60.8 million cases of flu. There were 274,000 hospitalizations and 12,500 deaths in the US alone. So it's pretty significant. So as Dr. Cooper was saying, when is flu season? Generally, it's thought to be from about October to sometime around March and April, and by May, it's thought that the flu season is generally over. The peak of the flu season tends to be between December and March, but it can really fall anywhere in between there. And you'll see later on that it kind of varies by season when it peaks, if it's an early season or a later season. The way that the flu is monitored in the U.S. is our country is divided into 10 different regions that so we're broken into 10 different regions that report the flu. We're in region 6. And then there's a live updates on the flu. So when you get a positive flu result, it's reported to the CDC, and the CDC tracks it so that they can see the trends as it moves across the U.S. One way to see it is to go to It's called Flu View, and it updates every week. So right now we're in week 44. And this is a table of flu for the region. So in Region 6, where we are, 3 out of 5 of our regions are reporting flu. We've had a few cases, not a lot. Most of them were seen in Region 4. And as you can see, there's already been 1 pediatric death so far this year for the flu. So this graph, it represents percentage of physician visits for influenza-like symptoms. The red line is the current year, the red line with the triangles right here. The dashed line is the baseline, like the national baseline for flu visits. This gray line is the 2009-2010 season, and you can see that it started, this is the number of weeks, so it started in the springtime, it peaked towards the end of the year, and then it decreased by the time it got into 2010. The blue line is 2016 to 17, and you can see that it was a pretty bad season, but it peaked more in the February-March time. Our line right here, it shows that there's starting to be a pretty steep increase in the number of people visiting doctors for flu-like symptoms. That doesn't mean confirmed flu cases, but flu-like symptoms. This graph, this is the positive flu results from May until November. So it's from theoretically the end of last flu season to this season. The majority of cases right here are influenza A, type H3. The next one, this orange one, is influenza A type H1, which is the one that was from 2009. The other ones are the little yellow one, that's influenza A unsubtyped, and then these are influenza B, the Victoria and the Yamagata strain. And then this graph over here, it just breaks down which strain out of the H3, what sequences are being found more. This graph, it's the number of positive tests for the 2017 to 2018 season, so our current season broken down by age group. The light green is children 0 to 4 years of age. The light blue is people 5 to 24 years of age. The dark blue is 25 to 64, and the purple is greater than 64 years old. So far, this one, the H3N2, is the most prevalent this season. It's fairly evenly distributed amongst people that are 5 years old and older. So it seems to get not the little babies, but older people. It still is more cases in the greater than 65 population. For the H1N1 flu, people between 0 and 64 years old are most affected. And then people or children younger than 24 account for the majority of cases. And that's the one on the bottom here. And then the other three are influenza B. And you can see that the Yamagata strain is kind of evenly distributed, as well as the untyped ones. And the Victoria strain of influenza B is not very common this year so far. So annually, influenza has a huge impact. It's responsible for deaths, hospitalizations, and a large economic cost. The economic cost of the flu can be broken down into the direct costs, the indirect costs, and intangible costs. So direct costs are the things that you can put a monetary value to, such as hospitalizations, doctor visits, costs for medications. Indirect costs are inferred costs. So that's something like lost productivity due to work, missing work, decreased performance at work, and premature death. So you pass away before you can complete like your lifetime. And then intangible costs, those include things like pain, suffering, and decreased quality of life. Intangible costs, it's difficult to put a monetary value on them, but they cause an effect on people. So the direct costs, there's 50 to 60 million people affected by the flu annually. 50% of these people visit their doctor. 25 to 30 million visits are from school-aged children and young adults. And annually, there's about 114,000 to 140,000 hospitalizations. Most of these occur in the very young children and the elderly population. Indirect costs, so those come from loss of productivity and work absenteeism. This contributes the most significant economic cost of the flu. On average, there's 0.79 to 4.9 days of work missed, and the peak time that people miss school is, or school or work is December to March. It's thought that during that time, 10% of days missed are due to the flu. Sick kids is significant because if a child is sick, parents have to stay home to take care of them. The average time that a child is sick or that a parent has to stay home to take care of a child is 3 days. So that means that the child misses school for 3 days and the parents miss work for 3 days. So the indirect costs also include, so it's estimated for every 100 non-vaccinated employees, 52 working days are lost. So that's a pretty significant amount. It's almost 50%, or it's a little over 50%. And so it would be smart for employers to encourage flu vaccines in their employees. And then I saw this in multiple sources about healthcare workers tend to continue to work through their illness. I think that's probably true. However, it's not a great idea because we come in contact with so many people and we can easily spread the virus to them. So I think it's important for healthcare workers to remember to, one, get their flu shot, and then also if they have symptoms of the flu, to not come to work. So there's about 20 million days of restricted activity. That's just from people not feeling well enough to perform at their normal level. There's about 100 million days of bed disability, meaning people are sick and actually staying at home in bed. It accounts for about 7 million lost days of work and about 22 million healthcare provider visits. Indirect costs are 10 times higher than the direct medical costs, and it's estimated that they are about $10 to $15 billion per year. Intangible costs, these are a little bit harder to quantify, but they include things such as like quality of life, impairment of function, decreased performance, stress on the infected individual who's sick, the burden of care on family members, and then infection in elderly people. Infections in elderly people is associated with a significant decline in their physical functions. And so if whenever somebody's in bed, they lose muscle mass and so if elderly people get sick with the flu and they're in bed, then they can get significant physical decline. The social impact of flu, it increases the demands on the healthcare system during flu season. It can cause long-term illness, it can cause disability, and it can cause death. So there's worldwide, or in the industrial world, there's 3 to 5 million cases of severe influenza annually, which leads to 250,000 to 500,000 deaths. People who have cardiovascular disease, pulmonary disease, or chronic illness, there are 50 to 100 times greater death rates in those patients. And people who have 2 or more comorbid conditions, it's even higher. This graph, it shows the pediatric deaths by week. So for the 2014 to 15 season, there were 148 pediatric deaths. This is in the US alone. The 2015 to 2016 season, there were 92, and then 16 to 17, there was 109. So far in the 17 to 18 season, there's been 1 pediatric death. Even though sometimes the pediatric deaths aren't as high as like adults, I think it's important to talk to our patients about the flu can cause death in children, and if there's a way to protect them, we should encourage our parents to vaccinate and protect them. So the flu vaccine, it does work. During the 2014 to 15 season, it's estimated that it prevented 1.9 million influenza-associated illnesses. It's prevented close to 1 million medical visits, and it prevented 67,000 hospitalizations. The 2015 to 16 season, it's estimated that it prevented 5 million illnesses. It's estimated that it prevented 2.5 million medical visits, and that 71,000 hospitalizations were prevented just by getting the flu vaccine. So for the flu vaccine, vaccine development starts around February of the previous season. The first step is that the World Health Organization, they meet and review surveillance data from the previous season. Then they look at trends in the viruses, and they discuss candidates for the next vaccine. And this is for global vaccines. For the US, then the FDA meets with the Vaccines and Related Biologic Products Advisory Committee. They consider the recommendations of the World Health Organization. They review and discuss similar data within the US, and then they make the final decision about the vaccine viruses that are going to be licensed and marketed in the United States for the upcoming year. Vaccine production, it takes 6 to 8 months from when they decide what viruses they're going to include to when they have a vaccine on the market. During this time, the circulating viruses may change. If there's a significant antigenic shift, then the vaccine, or a significant change in the virus, the vaccine that's being developed for the upcoming year may not be effective. So this year, there's the trivalent vaccine and the quadrivalent vaccine. The trivalent vaccine is Influenza A, Michigan, H1N1, Influenza A, Hong Kong, H3N2, and Influenza B, the Victoria lineage. And then the quadrivalent vaccine, it has those 3 viruses, plus the Influenza B Yamagata lineage. So who should get the influenza vaccine? It's recommended that all persons 6 months of age or older who do not have a contraindication to the vaccine receive the vaccine. It's especially important that we stress vaccination in high-risk groups. So that's children 6 months to 59 months old, adults older than 50, people with chronic illnesses, immunocompromised people, women who are pregnant or may become pregnant during flu season, and then children and adolescents who are receiving aspirin therapy. We want to make sure that they get the flu vaccine because they would be at risk of Reye syndrome. And then residents of nursing homes and long-term care facilities, and the caregivers who take care of people who are at risk. So the recommendations for pregnant women, All women who are pregnant or might become pregnant during the flu season should receive the vaccine. You can give the vaccine at any time during pregnancy, and it can give immunity to the mom and to the baby for about 6 months. The live attenuated vaccine, you shouldn't give live attenuated vaccines to pregnant women or immunocompromised people anyways, but you can't give them the live attenuated flu vaccine. It's not on the market this year, but if it were to become back on the market in the future, just remember not to give it to pregnant people. Same thing with immunocompromised people. The live vaccine should not be given, but immunocompromised people should receive an age-appropriate vaccine. Because they're immunocompromised, their immune response may be blunted, so they may not get the full protection that a regular immunocompetent person may. And then you may want to think about timing of the vaccine so that you can either give it before or after a period of time if you do immunosuppressive interventions. So if somebody is going to go for chemotherapy, you could give the vaccine about 2 weeks before so they have a chance to build up immunity before they get the chemo. So when should we give the vaccine? Ideally, we would give the vaccine before there's any flu activity in the community. The goal is to give the vaccine by the end of October. That's because it takes about 2 weeks to build up immunity, and then it's early enough in the season if it's an early season. Vaccines should be offered until there's no more virus circulating and there's no unexpired vaccines available. And then children who are 6 months to 8 years, because they require 2 doses of the vaccine, we need to try and get them their first dose as soon as possible so that they have time to get their second dose, ideally by the end of October, but before the flu season really hits. And then just a side note is the deadline for flu vaccines for UH is tomorrow, the 17th. So that's just, again, what I was saying. Children 6 months to 8 years, they need their first vaccine as soon as possible. And then the second dose has to be given 4 weeks after the first dose. So this question comes up all the time in clinic. Who needs 2 doses of the vaccine? So something to ask is, has the child received 2 or more trivalent or quadrivalent vaccines before July 1st, 2017? The doses do not need to be in the same season or in consecutive seasons. It's just 2 doses of the trivalent or quadrivalent before July 1st. If the answer is yes, then you just give 1 dose for this season. If the answer is no, or you don't know, such as they're not in links or they're unsure if they've received the vaccine before, then you go ahead and you give 2 doses, and then you give them 4 weeks apart. And then this is just a picture from the CDC website with the algorithm, and this is actually posted in the clinic in case you have questions. So what are the contraindications to getting the flu vaccine? The only contraindication is the history of severe allergic reaction to the vaccine or any of its components. And if people are unsure, there's a list of all the ingredients on the manufacturer insert that comes with the vaccine. There's some precautions to giving the vaccine. You may weigh the risks and the benefits of giving the vaccine to people with moderate or severe acute illness with or without a fever, or people who have had Guillain-Barré syndrome within 6 weeks following a previous dose of influenza vaccine. As far as the precaution of giving it to people with moderate to severe acute illness, it's something to consider, but there's research and studies that show it's better to just give the vaccine when you have the opportunity. There's an article showing that people who come to pediatric ERs, if they're offered the flu vaccine and given the flu vaccine, it saves costs in the long run, because even though they may be coming with an acute illness, it's going to help them. You have an opportunity to vaccinate where they may not come back to clinic to get vaccinated. And so it'll save with hospital costs and then help prevent flu illness. So in the past, people with egg allergy, they were cautioned about receiving the flu vaccine. That's changed. So people who are able to eat lightly cooked eggs, like scrambled eggs, are unlikely to be egg allergic. Anybody with a severe reaction, so anybody with hives, they can receive the flu vaccine. Anybody with a severe reaction such as angioedema, respiratory distress, recurrent emesis, anybody that needed epinephrine or emergency intervention, it's still okay to give them the flu vaccine. And it's recommended to give it to them. The only thing is that they should be given the vaccine in a setting where they can be monitored for a period of time, and if there are severe reactions to it, that appropriate action can be taken quickly. So the side effects of the vaccine, some pain and redness and swelling of the injection site. Some people get a headache. Some people report a mild fever, nausea, and muscle aches. So some flu shot myths and some reasons why people may be hesitant to give the flu vaccine. So the myth, you can catch the flu from the vaccine. We hear that one all the time. The truth is you can't get the flu from the flu vaccine. It's made from inactivated viruses or virus particles, so they can't transmit disease. It can take about 2 weeks to build immunity from the vaccine, and in that time period, people could become infected with the flu, which is not the result of the vaccine, but they attribute it to the vaccine because they recently got the vaccine and now they're sick. Myth, healthy people don't need to be vaccinated. That's false. The flu vaccine is recommended for all people 6 months of age and older, and it's also recommended for healthy people who are at risk of spreading the disease. You can't spread the flu if you feel well. 20 to 30% of people who carry the flu virus have no symptoms, and then, like we said earlier, the symptoms may take 1 to 4 days to appear after infection, so you can spread the virus before you start feeling ill. Getting the flu vaccine is all you need to do to protect yourself from the flu. The vaccine plays a key role in the protection from the flu, but you still need to protect yourself by washing your hands, covering your cough and sneeze, and avoiding contact with people who have the flu if possible. So you don't need a flu shot every year. The body's immune response to the flu vaccine, it declines over time. That's one reason why you get it in October and it only has coverage for that current season. Annual vaccines are the best way to protect yourself, and then because the flu strains are always changing, the vaccines change as well, and so you need to get the current vaccine. The flu is just a bad cold. It's not. It causes serious illness and death, and more than 200,000 people are hospitalized annually due to the flu. Getting sick with the flu is not that serious. It is. Since 2012, there have been between 12,000 and 56,000 deaths related to the flu, and it causes significant illness and can disrupt work, school, and social life for up to 2 weeks during recovery. Flu shots don't really work. I got the vaccine and I still got the flu. So sometimes they don't work as well as we would hope they do. The vaccine reduces the risk of contracting the flu by 50 to 60%. Although it's not 100%, that's still a good percentage. The vaccine effectiveness is subject to variables such as the amount of time between the vaccine and the exposure to the flu, the age and health status of the person who receives the vaccine, and then the match between the circulating viruses and the current vaccine. Myth, the pharmaceutical companies make a huge profit off of the flu vaccine. Not true. They do make a profit. It's a small profit though compared to the costs of flu infection, and the flu is only made by a handful of companies, and so it's not a money-making business. The flu vaccines contain harmful ingredients such as mercury and formaldehyde. Most of the flu vaccines are single-dose vials or pre-filled syringes, so they don't contain preservatives such as mercury and formaldehyde. Flu vaccines can cause neurologic damage. There were reports a couple years ago about somebody got the flu vaccine and then they could only walk backwards. That was determined to be psychologic, not related to the flu vaccine. There's this girl, I think it's from Florida. Supposedly she got the flu vaccine and now has severe neurologic damage. There were some cases of Guillain-Barré associated with the flu vaccine, like back in the 70s, I think. Now they say that there's no association, or if there is, it's minimal, such as 1 in a million, and that you're more likely to get Guillain-Barré from an influenza infection than from the vaccine. So there's no evidence that the flu vaccine causes neurologic disorders. Influenza can, so the vaccine is safer. And then children with neuro disorders are encouraged to get the flu vaccine because they have a higher risk of complications. And then 50% of the children who died in the 2009 season had underlying disorders. So this is a graph saying why childhood vaccines, the flu vaccine compared to other childhood vaccines. So some parents believe that it's less important. 59% of the parents who reported that their child did not receive the flu vaccine, 14% did. Some people say that it works less well. 21% still did get the vaccine. Some people believe that it has less testing, which I guess in theory is true because it's tested for a shorter period of time prior to being distributed, but it's still tested to make sure that it's safe. And then it has more side effects than regular vaccines. We already talked about the side effects, which is pretty much the same as other vaccines. So how can we help our patients? We need to look for opportunities for discussion of the flu vaccine. This is especially important in children who are born like January through, I guess, like late winter, early in the year, because those children aren't going to be 6 months old during flu season. So you won't address it necessarily during their well child checks when they're babies. But it's important to discuss it for them, as well as in their parents and other children in the home can get the flu vaccine, and then to prepare parents for next year that they would be receiving the flu vaccine. It's good to discuss the flu vaccine along with other childhood vaccines. So, for example, the baby's 6 months old now, you're going to get your 6 month shots as well as the flu vaccine. That way it's not thought of as like a separate vaccine, it's just thought of a regular scheduled immunization. And then there's been research saying that kind of promoting the flu vaccine, like with mailers or something saying that the flu vaccine is available, it helps bring people in, because if people aren't sick, they tend not to come to the doctor unless it's a regularly scheduled well child visit. So reminding people that the flu vaccine's available and come in and get it. And then parents with concerns, we should talk to our parents, address the questions and concerns about the vaccine and listen to them. It's appropriate for parents to be concerned about what you're giving your child and what the risks and the benefits are. And so if they ask questions, keep an open dialogue with them, address the questions. Give parents clear factual information to help them understand the importance of the vaccine. And then if parents refuse the vaccine, offer materials for them to review later. Don't pressure people into getting the vaccine, encourage them. But if they are adamant that they say no, offer them materials to look over at home about the risks and the benefits of the vaccine and why we think that it's a good idea. One thing that I also tell parents is, I always say, I got the flu vaccine, I gave it to my daughter, I wouldn't ask you to do something for your child that I wouldn't do for my own. So, and then just keep an open dialogue with parents and patients about the vaccine. That's it. Any questions?